Hysterosalpingography. And gentlemen, usually you won't participate in these exams due to the nature of the exam itself. So although, Mr. James, you said you set up for one, right? And certainly you can set up for one, get the patient in the room, get them dressed, but not be in the room during the exam. So basically, this type of exam is diagnostic and therapeutic. Okay, so diagnostic in that we're looking at the uterus and the fallopian tubes. And therapeutic in the fact that if a fallopian tube is not open, it can maybe a little bit more pressure applied to unblock the fallopian tubes for whatever reason it may be blocked. So, so what other exam do you know that's therapeutic along with being diagnostic? Do you remember? You learned it not too long ago.
Enema?
Yes, a bariminima, that's right. Sometimes bariminemas, if there's telescoping, you know, it can, more pressure can be applied and hopefully reduce the telescoping. What is that called? The telescoping about?
Intussusception.
Intussusception, very good. Okay, so there, so HSGs can also be therapeutic also. Not that it feels therapeutic, it, just like the BE, meaning that it can reduce some issues. So this is, here we have what an HSG looks like. You can see some of the instruments here. We're going to talk about the different instruments used. Contrast media is inserted. I'm not going to say the word injected because that's like more for a vessel, but is inserted or introduced into the uterus. Now, the uterus is bigger than this, but this is the endometrial portion. This is the endometrial canal. Okay, so here's the endometrium area. And then doesn't that look like a fish? An angelfish?
Yes.
Oh yeah.
I mean, maybe I was drinking.
I see it.
But that looked like a fish to me. That is just the contrast media. Let me turn off the lights a little bit. And you've got this on your PowerPoint. This is the contrast media being expelled into the peritoneal cavity. Okay. What's around the uterus, anatomy-wise? What's all packed in there? Bladder. What else? Intestines. So the contrast media is going out the fallopian tubes and just going in through and out the bowel and all of that area. The fallopian tubes are what the arrows are pointing to, this little spring-like structure. Look how small they are. Okay, so that's the fallopian tube. So the doctor should be able to see that, but also when we see spillage, we know what? That the tube is open. That's right. When you don't see spillage out here, then there's something blocking it. Okay?
So you want to see spillage?
We do want to see this. They're not always as pretty as the fish, but we do want to see contrast media into the peritoneal cavity. It is ionated contrast media, but it's non-ionic and it'll just be reabsorbed into the body. So we don't worry about this contrast media being in the peritoneum. Barium, yes, we would never do, ever do an HSG with barium, right? So we're using ionated contrast media. Okay, so just looking at the anatomy, notice that what we were missing with that exam, with that picture.
Sorry, put it
No,
on.
that's okay.
Yeah. I know.
If I fall, just pick me
It's
up,
not there
okay?
anymore.
Oh, there you go.
Yeah,
I was
I know.
stepping over it.
Yeah,
See
she
how
did
good
too, sorry.
Okay. So, what did we not see on an HSG?
Ovaries.
The ovaries, right? We saw the uterus, we saw the fallopian tubes, and that was it. So we do not see the ovaries on an HSG exam. So, however, that's part of the female reproductive system. So usually an HSG is done with other tests to get the entire picture of the female anatomy. And so what other exam do you think might be done?
Ultrasound.
Yes, absolutely, an ultrasound. So an ultrasound, everybody, we can see the uterus and we can see ovaries. We can't see fallopian tubes. They're just too tiny. Sometimes we can see fallopian tubes if they're dilated, filled with pus or blood or stuff and that's not good. We don't want to see fallopian tubes on an ultrasound. So this, I'm gonna let you, look over the anatomy. You do not have to memorize these numbers. If you go into ultrasound, you do have to memorize those numbers. In ultrasound, it's up to you to determine, are the ovaries within normal limits? Every organ of the body has a range of what it should be. And when you're in ultrasound, you measure kidneys, you measure liver, you measure all sorts of things, and you have to know W, N, L, within normal limits or not. So we teach ultrasound 1 by 2 by 3. Close enough, right? 1 by 2 by 3. So ovaries, as we get older, shrink. And so in ultrasound, they're harder to find for older females. We're like, yeah, good enough. So again, some diagrams. I always laugh at these diagrams. The uterus is right up the middle. The fallopian tubes are out, and the ovaries are perfect and equal distance from the uterus. And that is pretty much not how it is in the body, which we'll talk about some variants. But looking at the uterus, and this is what I'm talking about. We're looking at the endometrial cavity right here. So the uterus is actually larger than what we're seeing on the ultrasound, on the HSG exam. Okay, so here's the vaginal canal. This is the external os of the cervix. This whole thing right here is the cervix. So you have an external opening and an inside opening into the peritoneal cavity. Uterine cavity. Peritoneal.
It's Monday. It's all good.
I'm sorry. I'm doing so much better on Tuesdays. So now another thing is, it looks like this is all sealed up. The Fimbria of the fallopian tube over the ovary is not sealed, so that contrast media does leak out. It's in close proximity and close to, but it's just, that's not a sealed area right there. So that's why the contrast media can come on out. This is a side view. Look at I've got this way up there. That's not how it is, but just again, here's the symphysis pubis, here is the bladder, and here is the uterus. Typically, the uterus is in a anterior tilt. The fundus of the uterus is anterior. Again, that is not how it always is. The uterus, everybody not lined up right up in the midline. It can be tilted. It can be retroverted, meaning this can be flipped over like that. So you can imagine if the uterus was tilted, it would be closer to one ovary, further away from the other ovary. So not a big deal with performing HSGs radiographically. Sonography-wise, you're having to hunt for all of that in the bowel area, right? So it makes it a little bit harder. But again, just showing you the relationship. So again, a cannula or a catheter is placed up through the vaginal canal into the uterus to introduce the contrast media. So some more anatomy. This is the fallopian tubes. And so, just look over that. You've had this before in your anatomy class, I'm sure. Was that like 10 years ago? So, purpose and the different parts. Fallopian tubes are the site of fertilization. This is where an ectopic pregnancy can occur, and this is life-threatening to the patient. So what happens is the ovary releases an egg. It travels through the fallopian tube. If there's sperm present, the sperm will be in the uterine cavity and meet the egg in the fallopian tube. That's where fertilization takes place, and then the fertilized ovum will come and implant in the uterine lining. The uterine lining during that cycle, a female's cycle, becomes what I call fluffy, so that the egg can implant. If the egg is not fertilized, then the there's no fertilization, so the lining of the uterus will slough off. That fluffy uterine lining will slough off, and that's a woman's period. Okay, that's the endometrial lining being expelled and then starting the cycle all over again. So when the egg and the sperm are united and the egg is fertilized and it doesn't travel like it's supposed to into the uterine lining, then the fetus starts growing, or the embryo starts growing at that point. So if it ruptures the fallopian tube, that can cause bleeding and possible demise of the patient. So when we're doing an ultrasound, so the female that's pregnant is now having severe pain. They bring her to ER, we do an ultrasound, we see the fluid build up in that fallopian tube, and they take the patient immediately to surgery. And hopefully, usually they're not able to save the fallopian tube. So luckily, the patient has another one, but it does reduce the chance of fertilization again. So, and it's life-threatening to the patient. So, now, what did I say that was? Ectopic pregnancy can be other places than the fallopian tube. It can attach anywhere inside the abdominal cavity, but the fallopian tube is the most common place for ectopic. And again, just another picture showing that this one's out of your Bontrager book. In fact, this information is found in your Bontrager positioning book, your reading assignment. Just another one. We have a broad ligament. You know, ovaries just can't go anywhere. All of this is attached. So here's the uterus, the fallopian tube. We have ligaments that hold them all together. Again, the fimbria is not way out there. It's in closer proximity to the ovary. And then you can see the external os. I'm going to show you here in just a few minutes on using the cannula. So usually my fist is a cervix. There's your external and internal os kind of thing. So it's a kind of a closed opening, just like the end of my fist would be or is. So the uterus, it's a very thick-walled muscular organ. There's parts to it, and again, the cervix is the part going into it. So this is what the doctor needs to see when they're going to insert the cannula into the cervix. Position changes with the fullness of the bladder. You saw that previous picture where the bladder is here and the uterus is right over it. Ladies, if you've ever had a pelvic ultrasound, they've wanted a full bladder, or gentlemen, if you've gone with your significant other to have a pelvic exam, they want the bladder full, or maybe you've heard about that. And so what happens when the bladder fills up, right? The bladder's collapsed, uterus is here. When the bladder fills up, it brings the uterus back. Instead of being folded over, it brings it like this so that when we scan it, it's opened up and we can easily scan it. The filled bladder is an acoustic window, so it transmits the sound waves. And so the uterus behind it is just, here's the big full bladder with the uterus, and we scan transabdominally and see everything that we need to see. So now with an HSG exam in radiology, what do we have the patient do? Ladies who've done this? Yeah, we do for insertion, but before they get on the table, instead of having a full bladder, don't we want them, do you have them go to the bathroom? Or ask them if they need to go to the bathroom? Anytime you have a pelvic exam of any kind, here is an HSG, there's other pelvic exams, we usually ask the patient if they need to go to the bathroom to make sure the bladder is empty. Just not for diagnostic purposes, but just for patient comfort. Again, another picture. Apparently, if I have enough of these, it'll be, embedded in your brain. Here they are in real life. Aren't they pretty? Again, I'm looking at the external cervical os. Again, you notice this one not so much. Do you see how shiny this is? There is a mucosal membrane around it, and we do want it nice and that's healthy, nice and shiny and mucusy. Is that a word? And then the vaginal canal. What is the vaginal canal? It's just the lower portion of the birth canal is just the entrance to the cervical os. So indications. So what you need to know about this exam and some of the other procedures we're going to learn about is that you need to know, why it's done, reasons, what we call indications for why the exam is being ordered, and then you also need to know contraindications why you wouldn't perform the exam or this particular exam. So there's, look at all these, look at all these indications. Typically, the first one is the most common one, infertility. Now, ladies that have done it, have you looked to see, somebody else over here who's done it over HSGs? Do you remember?
A lot of them are infertility.
Are for infertility?
Yeah.
If your hospital's associated with a fertility clinic, then this is a routine workup for a lot of women who have fertility issues. There are certainly other reasons. Anything come to mind? Okay, start looking at those indications. Anytime you get a requisition, just look at the indications and why it may be done. But any structural or functional defects? Oh, yes, lost contraceptive devices. What's dysmenorrhea?
Not
Difficult periods. So if it's painful or difficult. These are kind of all the same. Restoring patency of the fallopian tube, stretching adhesions around the fallopian tube, dilating narrow tube. So if the fallopian tube is narrowed, maybe from adhesions being around it, I don't know. Sometimes, right, they're out there with the bowel, so sometimes they can get kinked, and so that kind of stops up everything. So these are kind of all the same thing. The fallopian tube, the contrast media going through the fallopian tube sometimes will straighten those kinks and open them up and stretch any adhesions so that now it's clear for fertility. Endometrial polyps can be seen. Malignancy, fistula, pelvic masses. What's amenorrhea?
No.
No periods. Just say thank you and move on. People are worried about that. You're trying to get pregnant and you're not having periods, and that's going to be a big problem. Habitual abortion. This word is a medical term that we use, but we don't use that with our patients. We don't say, how many abortions have you had? What do we say? We say, how many miscarriages have you had? So a spontaneous abortion, I don't mean somebody going into a doctor, Planned Parenthood, and having the baby taken. We're not asking that. We're talking about we'll ask how many pregnancies, how many live births, kind of thing, when we're taking. So that's what we mean by habitual abortion. I remember doing an ultrasound scan on this woman, bless her heart, she was so nice too. Her and her husband were there, and it was their 9th aborted. They had 8 aborted pregnancies before, 8 miscarriages before, and now they were hoping this 9th one, would take. And it was like, oh, you're brave. So some people have a tendency to habitually miscarriage, and so they may do the workup to see what's going on with that. So any congenital anomalies that may be seen, and we'll look at that towards the end of some of the things. So make sure you know. I might ask you a question, what is the most common indication for HSGs? I might ask you which of the following would not be an indication for an HSG. So please be familiar with this list.
Are miscarriages detrimental to the health of?
Are miscarriages detrimental? They can be, depending on how they're handled. So, not necessarily though. People sometimes miscarriage before they finally become pregnant. So it's the body's way to maybe, I don't know why, but sometimes it happens because there's a defect and the body is miscarrying for that purpose. Or there might be something wrong. Sometimes the female may have a blood condition that doesn't allow for the baby to be carried to full term. There's lots of things that can go wrong.
What's the fistulae?
Fistula. A fistula is a blind curve. path off of, so like maybe the wall of the fallopian tube is weak, or maybe you can have fistulas with the bowel also, and so this is like where something has burrowed its way out, not like some sort of infection is usually what causes it, and so it's another opening that's not supposed
Oh,
to be
okay,
there.
okay.
So here are some other HSGs. So again, we're going to talk about these instruments. These instruments are in the vaginal canal, okay? And so again, here is the spillage. You can see it doesn't always look pretty like an angelfish, but you do see spillage on both sides, and you can barely see the fallopian tubes. Some of the spillage is obscuring those. This is why this is done under fluoroscopy, so the doctor can see the contrast media going out the fallopian tubes. So that's all that is. Notice a little bit of tilt here, a little bit of tilt there. They're usually not nice and straight up and down. So why would we not do an HSG? Any pelvic inflammation, discharge, or if they're right before or right after the menstrual cycle. Now, so what happens is what we're doing with the contrast media, it's coating the inside of the uterus. So if there's anything that doesn't allow for that coating to coat, the contrast media to coat the inside lining, then such as bleeding, anything, right? Because what's causing the bleeding? The endometrial lining is sloughing off, so you're not going to get a diagnostic study. It's going to compromise the study. Okay, so anything that would cause that, and then this is kind of almost the same. Inflammation would cause that. Uterine bleeding would certainly cause that. So these are all kind of the same thing. And then pregnancy, we certainly want the patient to be pregnant because then they would miscarry. So the contrast media, you've learned about that right in 162. You've been studying that. We use water soluble. These might be some of the different types of contrast media. Do you remember what type you use for an HSG when you're setting that? Okay, you use gastrographin? Okay.
No, I'm just
Oh, no, gastrographin tends to be for the bowel,
okay.
for drinking. So I'm not,
I said enema done.
yes, a very minimum, absolutely, you can do it with gastrographin. This is typically Hypake, Salpings, any of your water-soluble contrast media. So when you set up for this exam, let me caution you, when you set up for any iodinated contrast media exam, and I'm sure this has been taught to you, but just in case it hasn't, that you want to pay very close attention to what contrast media you're introducing. You're going to learn all types of exams that have contrast media associated with it. Arthrography, myelographies, HSG. You don't do that many kidney exams anymore, but you know you have a lot of exams with contrast media. So pay attention to what is needed for each exam. If you have a contrast media, maybe Omnipaque, anybody use
That's
that?
what we use.
Okay, you may use that for an HSG, not a problem, but just make sure that that's what is used at your facility for that exam. And you can imagine, Omnipaque may work for everything, so why have all the different ones to get messed up? So the story is, the student, it was a myelogram. A myelogram, we're going to learn about that in here, but that's what contrast media is put into the spinal cord, okay, and injected, inserted into the spinal cord, and then we do images to see that. And so you have to have a specific type, well, Omnipaque is the one, and they used, the student did it, and they used something like Conry 60 that they would use for an IVP. Because they were doing a lot of IVPs, and every day they did an IVP, and so they would go to the cabinet and pull out the Conry 60 for the IVP. Every day the Conrad 60 for the IVP, and then we had a myelogram, and they pulled out the Conry 60 for the myelogram, just because that is what they have been doing. That's what we always do, not for myelogram. So the patient, that kind of contrast media inflamed not inflamed, it irritated the spinal cord. It was very painful for the patient, and it could have caused quite a bit of damage. That happy ending, so whose fault is it? The student was there, the tech was there, and the doctor? Yes, it's all their fault from everybody. And it was it was settled. Student finished the program, yay, happy ending with that. But that's just my point, that you need to look. We do a lot of things that are habit, and you will develop those habits, and a lot of those habits are good, but then you've got to just pay attention. What's the other thing you look at when you pull out contrast media out of a cabinet? Yeah, lot number, expiration date, making sure. So you have to slow down enough to pay attention to these things. We get going so fast, we just grab and go, right? So just make sure that so the water soluble, and this will be for any water soluble that's introduced into an organ. It's because it's water soluble, it's going to be absorbed in the body quickly. And the only other problem with that is it might be a little bit more painful. It irritates the lining of the organ, and in this case, the uterus. And so it can be a little bit irritating to that. We used to use oil. That was very soothing. It wasn't irritating to the lining, and it did not absorb quickly at all. In fact, it could persist for quite a length of time. But we don't use oil contrast medias anymore. We're all using water soluble. And so, again, that's just very opaque. Water soluble, you have to start imaging fairly quickly because it's starting to absorb into the body, whereas the oily is, again, more persistent. It's very opaque, so it makes for good images. I have some up here water soluble. I have some up here images that are oil, and you can typically tell the difference because the oil is much more opaque. And so we use a diidol or lopidol, and you won't see those again.
I have a question
Yes.
about that. Would using an oily contrast, since you're getting this exam done around probably ovulation time, could that block a pregnancy because it's still in there?
That's a good question. So would the oil block the pregnancy from happening? No. No, it's not thick oil. It's very, very thin. And a lot of times after the exam, we have the patient go to the restroom so that by gravity will come out of the uterus, right? But you've got that contrast media that went through the fallopian tubes out into the peritoneal cavity. Oil-based contrast media absorbs about 1% per year. No, 1 cc per year. So it absorbs, but it's very slow. So it wouldn't hurt the uterus or the fallopian tubes. It would just be persistent out in the abdomen area. So if you had follow-up exams a little bit later, you'd see that oil-based contrast media in the peritoneal cavity. So patient prep, this is iffy. This would be the ultimate exam. Typically, we don't have the patient take a laxative the night before or have enemas the morning of exams. We usually are able to see the uterus and the fallopian tubes. But you've got to remember, if there's a lot of bowel gas or fecal material around there, it may obscure some of the imaging and make it less diagnostic. So unless that's an issue, usually what we would do is do the exam, do a scout. If that's an issue, then maybe reschedule with them having to do that. So this is, I don't know, correct me if I'm wrong. I'm going to talk how I think it is, and if it's different at your facility, let me know. But this is, if the first attempt at an HSG is not able to happen because of that situation. Okay. So this, we do want an empty bladder before the exam, and again, that's just for the patient's comfort. Pre-medication, it's between the patient and their doctor of what they want to order. Anytime the cervix, this is now, my fist is the cervix, anytime the cervix is dilated, it can cause pain. So ladies, your menstrual cramps, cervix is dilating to let the endometrial lining slough out for a period. Labor, right? Labor. If you have an endometrial biopsy, you know, where they go in and want to take some tissue, you know, to see if, what's going on. Again, dilating the cervix. So that's what causes a cramp. That's what causes a cramping. So pre-medication can be anything from Valium to
Like a pain medication?
lidocaine injected into the cervix to deaden it, to Motrin, ibuprofen prior to. I had a girlfriend, I asked her, she had an HSG, and I said, how was it? And she said, oh, great, I